This is about challenges in polypectomy training. So not just challenges in doing polypectomy, but even more difficult than that, potentially, challenges in training people to do polypectomy. And this session is based on the ESGE 2023 Polypectomy Curriculum, which I was lucky enough to be involved in, as were a number of the other members of this organization. So the objectives of the session are to explore how to create an optimal environment for polypectomy training, explore the fundamental knowledge necessary when completing training in polypectomy, and discuss strategies to overcome technical challenges encountered during polypectomy training.
So we need to know about the features of LNPCPs, means large non-pedunculated colorectal polyps. So a theory about their classifications is interesting, definitely in EMR. It's maybe a little bit less relevant to smaller polyps, given cancer is much less likely to occur in those. So as I said, we need to know about our equipment. If possible, CO2 is definitely the way to go. Instead of air, patients will feel a lot less discomfort, and it's also a lot safer. We want to emphasize on the process for patient consent. You need to have a little bit of time to address the possibilities. Obviously, it's not to scare them. It's just an honest conversation and make time for any questions they might have. Also, in terms of EMR, I think it's very important to explain this is a sort of two-stage procedure, which is done at time 0 and after 6 months. And then when does a trainee start an EMR procedure? Luckily, we have some scores for that. And I think SMSA and SMSA Plus scores are the ones definitely to use. Find your level and try and upgrade as you go. And maybe avoid to pair with an assistant, a nurse who is also in training. So you have people working around you who are well trained already, so to avoid complications. We can do hot snare EMR, cold snare EMR. Everybody knows that right now, but we will go into that a little bit later in the day, when to use what. We know that you should have your polyp at a 6 o'clock position, that we want some normal tissue around it. We don't want to use diathermy when we start it cold. We're not going to plug it in. It's a recipe for disaster. And we work sequentially. We don't want to, if not necessary, have a go at a big chunk if we can perfectly do it piecemeal, safely and efficiently. We need to know how to inspect a defect mainly for 3 things. Most importantly, is there any residual adenoma? Is there important bleeding, or are there any signs of perforation? There is enough literature on the defect published recently that will explain everything about the post resection submucosal features. What about lifting for hot snare? We want to do it sequentially. You don't inject the whole polyp all at once because it will flatten it out rather than giving you a little hill to make the snare sit around. You will also use your lift to bring your polyp into the desired direction. So you bring it towards you, into the lumen, away from a fold, and so on. The snare handling is important. Obviously, you choose an appropriate snare. I think one of the most important things is that you don't have to use 30mm snares in the right colon unless you're really keen to use some clips. Don't do it. Start at an edge. Don't start in the middle of polyp, and work again from defect over polyp, and every time try and have a rip of normal. Always check mobility of the captured tissue in comparison to the colonic wall. It should not move when you move your catheter. you need to know about electrosurgical energy. You need to know your processor. If you can, microprocessor controlled electrosurgical units will decrease your adverse event rate. We tend the tissue away from the colonic wall in order to avoid deep thermal injury. We also don't coagulate visible tissue. After we've inspected the defect, we try and remove all visible tissue. We will not ablate it. Only bleeding vessels should be treated, and we should inspect the muscularis propria for any features of deep mural injury. We can use the Sydney classification for that, which is very comprehensive. How about terminal ablation of the margin of the defect? We use the scope. We avoid to work with the catheter and move it up and down through the scope. No, we use the scope and leave our catheter alone, and that will give us much better tip control. And you make sure you have a stable position and you ensure there are no gaps, because it's also proven that when the snare tip was incomplete, that actually the effect of a complete snare tip of the margin is lost.
So, I mean, before one can even think about starting training polypectomy, there are certain core competencies that need to be addressed. And this has been covered in most of the talks and will probably be covered further during the day. So I'm not going to spend a lot of time on that. But I mean, of course, it goes without saying you have to be competent in diagnostic colonoscopy by attaining KPIs, accreditation through local institutions or local national standards. And the one thing that really needs to be emphasized is that competency-based assessments is key and not volume-based assessments. I think Lob covered theoretical knowledge quite well, so I'm not going to chat about that. And of course, you have to be competent in small polypectomy before trying to move on to EMR. Often asked or I often tell trainees the only difference between a small polyp and a large polyp is size, because basic technique is fundamental and key for either. You have to be competent in managing emergencies. As Lob said, don't start something you can't finish. And if you'll end up in trouble, you have to be able to bail yourself out. So these are some of the endoscopy unit standards which should be in place prior to even thinking about starting a training program or training anyone in polypectomy. So pre-procedure pathways, the first thing is to have adequate patient assessment measures in place to assess things like mobility. Key to identify predictors of poor bowel preparation and address this before even proceeding to a colonoscopy. Getting previous endoscopy reports, previous surgery as predictors of difficult scopes and difficult procedures, so one can prepare to tackle these. Looking for patients' comorbidities and fitness for sedation or anesthesia. Of course, anticoagulants are a big issue in terms of polypectomy, and one needs to adhere to local international guidelines and always consult your cardiologist, hematologist in the multidisciplinary team. Communication pathways are essential, and ideally needs to be a combination of different communication pathways in the form of both written information through pamphlets, sheets, face-to-face communication, and remote consultations. I think we've all become accustomed to this during COVID, but it needs to ideally be a combination of this. And I think a key is also to have this done in a variety of local languages, and also to make sure that it's understandable by patients and not use medical jargon. So administrative issues, and this really ties into planning procedure lists, and the two key factors to planning procedure lists are allocations of both time and staff. In terms of time, the complexity of procedures needs to be considered, and training considerations. Not only training considerations, but the level of the trainee needs to be considered. The senior fellow is a lot different to the junior fellow, and the junior fellow might need a lot more time on the list rather than the senior fellow. This always has to be weighed up against service delivery needs, and again, the ultimate goal is patient outcomes, and we shouldn't lose track of that. Staff allocations are crucially important. Allocating nursing staff based on the complexity of the procedure, based on their experience, based on equipment needs. Some staff may be more well adept to using certain pieces of equipment, and those are the staff members you might need in the specific procedure. But it's not just nursing staff, it's anesthetics services as well, and the other staff members like scope processors and cleaning staff that prepare the room prior to the procedure. Equipment checklists need to be checked prior to every procedure and prior to every list.
So, okay, look, so great. You've demonstrated the size, and then, you're a very competent EMR. So we won't go into competency. That's for a later session. So we think you can do this. So why don't you take it away and take us through the technique you were expecting from your trainees when they're doing this. And we can try and highlight here in the studio some of the difficulties that might come up.
Okay. I try and get it at a 6 o'clock position, but as you can see, as I advance, I'm really coming up to it, like it's the wall in front of me.
I really think that the risk of invasion is very low based on how this polyp is behaving through the resection. So
You also already took a piece, right?
having a third piece isn't going to matter much in my mind. Yeah, I think it's possible. You could have taken that.
I think it's possible.
In one piece. You would want to have a hefty lift, and then you're going to want to push the snare down so that you can capture it all.
I mean, for you, Naz,
and then really, do your mobility check.
Naz, we wrote that article together. It's what I'm driving at, right? The en bloc versus the piecemeal thing. For you, what are the pros and cons of, one piece versus 3 or 4? Is there a difference? And if there is, what is it?
Yeah, I guess the first thing is you need to make a decision before you start the resection. So if you're going piecemeal, then having a few more pieces versus 2 pieces isn't going to make much of a difference. The main thing is that if the lesion, the main point of that reason is that if there's nothing to be gained, i.e., you don't think there's a risk of subluxation, then all you're really doing by trying to achieve it on block is, one, making the resection arguably more difficult, and also increase the risk of which really there is nothing to gain by doing. So to me, if I will make a decision at the time of lesion assessment.
So I was telling her about a trick I learned very, very early on in my EMR career, and it was at Westmead, and I learned it from you, David. I actually, it was the best trick you've taught me. So can you hold, Philippe? So
Now we're gonna hear it.
No, I mean it. I'm serious for once.
Push the scope in.
So what I can do now, and what we will all tend to do, is this, right?
Yeah.
Don't do that.
No.
If you see you push your scope in. Okay, I'm really close now. Maybe not necessary to be this close, but instead of doing this, right?
Right.
Go in. Look at that. It's such a big difference, and it's a world of difference, and it changes everything. So just wanted to give that to everybody who's keen to do EMR and does it. This is the best trick